All right. Super. Thank you so much.
It's appropriate that we're having technological glitches as we're talking about technology and AI. With that, we'll invite Dr. Rob Marvin to come on up. Rob is going to talk to us about an update on assessment and treatment of psychotic disorders. As all of you know, or should know, Rob is our Executive Vice Chair and Vice Chair of Clinical Operations for the Department of Psychiatry and Behavioral Sciences. He's probably most proud of the fact that he's an epic physician builder and a self-admitted nerd. And we're very grateful to have him having joined our department, almost 2 years ago. So lots of exciting stuff that has been happening. So Rob, come on up, please.
Thanks, Ramon. Thanks for everybody who's brought me to this talk and given me the opportunity to give you guys an update on assessment and treatment of psychotic disorders here. I don't have much to declare. I do some lectures for psychiatry board certification exam and past funding from ABPN and NIMH. Today I'm going to talk about some kind of broad-ranging topics. So I'm going to go through very quickly overview, etiology, assessment, and treatment of schizophrenia. I want to shout out a TikTok artist. This is Christopher. This was highlighted in Newsweek a few years ago. He's a filmmaker and has posted a series of short films on TikTok illustrating what it's like to have schizophrenia. And he does a very interesting kind of walk through of what a day in his life would like, or a moment in his life would like, with hearing voices or seeing things or these distractions. And if you've never had one of those experiences where there's some exercises where you can put headphones on and kind of hear what it's like to have auditory hallucinations, he has a really kind of creative and informative way of kind of experiencing what it's like to just kind of have this stuff randomly poking into your consciousness all the time. Okay, let's talk about what is psychosis. Just the way my brain works, I have to have a conceptual model for things. I'm horrible about just memorizing individual facts. That's why I did poorly in psychopharm in medical school. So I couldn't remember all the classes and side effects of individual medications, but give me, this is how it works, I can elaborate on that. So for me, this is helpful in thinking about psychosis. There's a model called aberrant salience, or disruption in the salience network, that's been a model for looking at schizophrenia or psychosis for 20 some years now, probably. And for me, this really highlights kind of the common themes and allows me to kind of think about the different symptoms that people have. So if we think about psychosis, we're thinking about thoughts, experiences that are out of touch with reality. They're not connected to some, like, this is reality, this is not reality. So, okay, that leads us to think, okay, we must have a psychological mechanism in our mind that's making that distinction. This is reality, this is not reality. And that's really the salience network. So there's a network of interconnected circuits in our mind that actually processes internal information and external information to give it relevance or salience. This is important, this is not important. And then our higher cortical areas are putting relevance to that. It's important because it's this. It's important because it reminds me of that. It's not important because I don't need to deal with that anymore. Highly evolved, this is evolutionarily important, because it allows an organism to focus there are a limited amount of attention on the things that are important. You don't need to pay attention to all these other things going on. You're just going to look at that prey in front of you. There's good evidence now that at least in schizophrenia, there's disruptions in this salience network of how people's minds coordinate the importance of internal and external stimuli. So we think about this aberrant salience as the inappropriate processing of that stimuli that would either be meaningful or not meaningful or irrelevant. And we were able to tie that into some of the dopamine hypotheses of schizophrenia, because dopamine's involved in these different networks. And we can pull that together to account for and represent the symptoms of delusions, hallucinations in psychosis. We're now at the level of data to be able to kind of pull multiple factors together. So looking at different areas of the brain, this little graphic kind of points out different areas that are involved in the salience network, the amygdala, the dorsolateral ventral medial prefrontal cortex, anterior cingulate, hippocampus, striatum, and substantia nigra are all involved. And these have all been previously involved in schizophrenia. The idea around this salience network is that the generation of positive symptoms occurs when stimuli that would normally be irrelevant or unimportant becomes highlighted and tagged as important. And then through conditional learning, the more that's tagged as important, the stronger the connection, the more important that is, we get delusions. Negative symptoms through this network are thought to be the ignoring or discounting, not paying attention to things that people would normally pay attention to in the environment. Things that would be entertaining, or things that I got to go do my laundry, I got to go clean up this thing in the kitchen. Those are not tagged as being relevant or important in the person's internal salience network. And then we have negative symptoms of avolition and amotivation. Okay, so that's my conceptual model, and I can kind of think, no, I can pull all this other stuff into that. Let's take a step back a second and kind of just think about where we have schizophrenia, where it occurs. It's a fairly common psychiatric illness. It's in the top 10 illnesses contributing to global burden under WHO. If we're looking at incidence, kind of the rate of new cases, so the rate of having any psychotic symptom is about 50 and 100,000 people a year. For schizophrenia specific, is about 15. Prevalence is looking at one-time slices, so how many people are currently affected. If we're looking at a 12-month, it's about 4 per 1,000, and lifetime it's about 7.2, which is really where we get like that 1% chance of schizophrenia or prevalence of schizophrenia. The rate of schizophrenia is about even male and female, a little higher in males. Depending on the age of the population, that's skewed more towards males because males have a younger age of onset. So if the population of study is younger, there's going to be a higher incidence, higher ratio of male. If it's an older population, women tend to live longer. It's going to be skewed more towards women. Creates a significant burden. So WHO looks at the disability adjusted life year as a measure. So this is a calculation that looks at lifespan minus, or the disability age adjusted, or adjusted life year is the combination or the sum of the number of years that people have the disability and the years lost to their lifespan. So it's kind of a measure of total disability. And this chart is ranked by different groups in the different columns, or age groups in different columns, and then disorders in the rows. And you can see schizophrenia is ranking pretty highly up there, with the smaller number in each box representing those disability adjusted life years. If you look at some of the other numbers, it's clearly things that are very chronic or very serious illnesses that add to that disability. And then just so we have a frame of reference, looking at the course of illness over time. So if we're thinking about patients with schizophrenia, it's usually a relapsing and recurring illness. So for most people, the premorbid symptomatology is very little. They have very few symptoms premorbid. In their, as they're beginning to have symptoms, they maybe beginning to have some odd pseudopsychotic things. And then most people will have an acute psychotic break where there's a very florid onset of symptoms and acute illness. For most people, they'll have a pattern of fluctuating symptoms over their 20s and into 30s. For most patients, by the time they get to their 40s and on, they have more stability and less severe symptoms for most patients, less hospitalizations. Okay, what do we know about what's going on? Etiology. The current model is what we would call a diathesis stress model. So this is probably the same model we have for all of our psychiatric illnesses. So it's a combination of the individual's pre-existing vulnerability, so the diathesis, and then either stressful life events or environmental factors contributing. Said another way, neurodevelopmental substrate disruption that interacts with the environment and social stressors that produce the syndrome. And we have evidence from that from various lines of research. So neurotransmitter data, anatomical data, genetic data that we heard like a great talk from Dr. Cook on, and then certainly environmental data as well. Let's talk about neurotransmitters first. Dopamine is the most researched neurotransmitter probably in schizophrenia, so there's very, very strong evidence that dopamine dysregulation is a primary end result or cause of schizophrenia. We have strong evidence from that because our medications, almost all the medications we have, are dopamine D2 receptor antagonists. And then kind of in the inverse, substances or drugs that increase dopamine cause psychosis. So amphetamines and PCP act in that way. With dopamine, we have fairly well delineated pathways in the brain that can interconnect different parts of the brain, and we can roughly correlate the dysfunction in those pathways to specific symptoms, like positive symptoms, negative symptoms, and side effects. We also have good evidence from serotonin. Primarily, the evidence from serotonin is really our medications as well. So our second-generation antipsychotics are very potent in serotonergic activity. And then we have evidence from kind of substances as well, like the psychedelics that cause psychosis are serotonergic medications. So it's either antagonism, like blocking serotonin receptors, or inverse agonism, attaching and decreasing the activity at the serotonergic receptors that potentiates the action of the medications. And the thought that from serotonin point of view is this is a regulatory or co-regulatory mechanism for dopamine metabolism or dopamine release. So you can regulate dopamine release by regulating and improving serotonergic function. And then we also have evidence from kind of the regulatory neurotransmitters in the brain. So GABA is an inhibitory neurotransmitter. It's kind of the brakes of the brain. There's evidence that loss of GABAergic neurons unleashes or takes away that regulatory function and then increases dopamine and causes psychosis. Glutamate is a activating neurotransmitter, also is involved in regulating neurotransmitter dopamine release. And this is how PCP and ketamine potentiate psychosis as well. We have good evidence now from some of the genome-wide association studies that these GABAergic and glutaminergic receptors are involved in the pathways for schizophrenia and psychosis. So this slide is kind of a summary of what we've got going on with the neurotransmitters and the actions of this. The panel on the left-hand side is kind of the areas of the brain that are affected, the frontal cortex that are in blue, striatum in red, and temporal cortex in green, showing the differences in neurotransmitter activity in the different sections of the brain. And then the panel on the right is the linkages. So the idea is that in this pathway, the lower cortical glutamate affects the GABAergic neurons, affects GABA levels, inhibits the cortical control of dopaminergic neurons in the striatum, increases dopamine release, relating in causing those psychotic symptoms. Okay, let's look at anatomy here. This is a long-standing feature or a pattern that we've seen in patients with schizophrenia is loss of brain volume over time. When we just had x-rays or CT scans and then onto MRI, we've evolved our level of detail from kind of gross anatomical brain atrophy or decrease in volume to very specific areas of the brain that we can now look at with high resolution MRI. And if you look at these are identical twins, kind of a well twin and an affected twin. You can see the lateral ventricle size. So the little butterfly lateral ventricles are much larger in the affected twin. On the bottom panel, this is much more dramatic. And you can also see widened sulci across the top here, representing brain atrophy. So that's kind of a gross, less brain volume, less brain cells type of thing. If we look at kind of studies that have looked at more precise measurements of brain volumes, it's in those areas that we've implicated in the neurotransmitter dysfunctions. So the amygdala, the caudate, frontal lobe, hippocampus. And then also on this slide is the ventricles. Those bottom two rows, the third ventricle and the lateral ventricle, are greatly increased in size in patients who are affected with schizophrenia or psychosis. So loss of brain volume, loss of brain function. So why is that? The ultimate answer is we probably don't know. One of the theories out there is that there's some aberrant synaptic pruning. People remember this theory? Yeah? So synaptic pruning is why we can't learn Spanish at 30. Our brain undergoes a process of refinement. The idea behind it being that we're going to eliminate, decouple those connections that are weak and enhance those connections that are strong so that we can remember what we've learned growing up and survive. Okay? Errors in the synaptic pruning are thought to be one of the reasons for the onset and timing of schizophrenia. So something about the synaptic pruning process sets off the symptomatology or unmasks the vulnerability, maybe. Kind of connecting it to autism, the idea around autism around synaptic pruning is that there is insufficient synaptic pruning and there's too many connections left. And so that's the dysfunction in autism spectrum versus schizophrenia where there's an over pruning and decrease in brain volumes. Some other evidence we have, so looking at this from a different way, functional imaging. So this is looking at a functional MRI. So putting someone in an MRI machine, giving them a specific cognitive task, and then looking how the different parts of their brain are activated when they're actually doing a cognitive task. It is good at looking at very specific cognitive functions. So it's not necessarily a global picture, but it's more of a individual thing. So looking at memory, social cognition, and really looking at that salience network as well. Another way to use the MRI machine is just put someone in there and let them just be at rest. And so what is someone's brain doing when you're just kind of lying there thinking or just your mind is wandering? And they've showed some differences between controls in patients with schizophrenia and just how their brain idles. Again, connected to the salience network and kind of the cognitive functions that are running in the background. Okay, let's turn to genes here. We heard a lot from Dr. Cook about different genes involved in autism spectrum, and we're going to kind of talk a little bit about that here. So starting with just inheritable risk. So if we start at the bottom and look at monozygotic twins, there's a 50% chance of inheritability. So if one twin has schizophrenia, 50% chance the other twin might get it or present with that. As we go up the chart, the degree of relativity decreases, and so it rapidly decreases. So by the time we get up to like second level, like cousins, aunts, and uncles, the risk is just slightly above the general population. This is kind of a callback to Dr. Cook. So we've looked at tens of genes, hundreds of genes maybe now in schizophrenia. And they are falling into those similar buckets that we have with autism. So they're copy number variants, they're deletions, they're de novo gene mutations. And then looking at about where all those genes are working at the cellular level, all those little purple ovals there are different genes that are associated with schizophrenia in these studies and where they're acting within the synapse and nucleus of the cells. So we've got a lot of data that there's a lot of different genes that contribute to the risk for schizophrenia. So where does that come together? So I like this slide because it kind of pulls a lot of the genetic data together, or the variance in the risk for schizophrenia. So if you look at that inner ring, the green ring, that's the just general inheritable risk, the 20% that's non-inheritable, and then the 80% that's just heritable in total of the risk. And then of that 80%, we know, I don't know, what is that, 25, 26, 7, 8, 29% of it, we know where it's coming from on the right or the left-hand side. And then of that piece, we kind of know a little bit more about where some of those genes are coming from. So there's big chunks of genetic inheritability that we don't know exactly where it's coming from, but we've come so far in 20 years to identify these genes. Okay, let's look at some environmental factors. So this was a thing that was probably more common when I was in medical school and in residency, was maybe looking at these risk factors, like the importance of different environmental factors in schizophrenia. So these are all like a summary of different things that incur at least some risk for development of schizophrenia. So obstetric complications. So if a person is born at the time of their birth, there is obstetric complications, that incurs some risk. Born in winter in the northern hemisphere. Childhood trauma, urban living, being a first-generation immigrant, and then cannabis use. We'll talk about that in a second. The thing that I kind of attach all these things together, these are all neural developmental risks. So a kid who has a developing brain, their brain is sensitive, their brain is malleable, their brain is going to be influenced by environment and stress. And all of these things are representing a stress to a developing child's brain and increasing that risk of schizophrenia in the context of maybe having some set of genes that puts them at risk to begin with. Okay, let's talk about cannabis. Cannabis and psychosis do not go well together. Great evidence that says the more you smoke, the more you're at risk. The panel on the left is a risk of developing psychosis based on exposure. So the more you smoke, the more at risk you are. And those are just the different lines of the different studies that looked at that. And then the panel on the right is kind of combined or summarized results. So the risk of developing either a psychotic disorder or having a diagnosis of, frank diagnosis of psychosis or schizophrenia from risk from using cannabis. So bottom line is, if people are at risk, they really shouldn't be smoking. I mean, there are hundreds, thousands, millions of people out there that smoke all the time and never become psychotic. So we know that that's not a one-to-one relationship. But people who are at risk, strong family histories, clear cause and effect relationships for patients, really should be addressing that. Okay, so let's kind of pull all this stuff together. So we know there's some nature. This is the genetics. This is the developmental processes that are coming together, the role of neurotransmitters, maybe stress vulnerability, combined with nurture or the environment, what developmental experiences, life stressors happen for the patients, their exposure to cannabis. This leads to multiple areas of brain dysfunction. So we have problems with connectivity, neurotransmitter dysregulation, that synaptic plasticity, pruning, synaptic strength. This is that idea of that salience network and how those things are coded together. All of that resulting in our symptoms that we see. So the hallucinations, delusions, thought disorder, affect changes, cognition, and we call that schizophrenia. Okay, so we know where it comes from. How are we diagnosing this? Okay. Some things to remember. These are the diagnostic pearls here. So there's really no specific sign and symptom that's just going to say, okay, this person has schizophrenia. So it's a process. We know that the duration of untreated psychosis results in worse outcomes. So when you're seeing a patient, if you have experience, you can probably guesstimate how long they've been psychotic by the severity of their symptoms, how well developed their delusions are. So you can kind of just guesstimate some of that, I think. Some things to remember: that the symptoms are going to vary over time, especially early in the course of schizophrenia. They're going to be waxing and waning. Patients will have days, weeks of symptoms, and then resolution of symptoms, and then 6 months later might have some more symptoms. So it really needs to be a process. We need to take developmental factors. So is this person 14 when they're having these symptoms, or are they 24? A person's life events and where they're at, how much education they've had, really varies between that 10 years, and how they present and their understanding of the illness is going to be very different. In the end, our goal is the same, though, really trying to identify target symptoms, have some measurable outcomes, and promote care and recovery. Okay, I talked a little bit about this, but when we're thinking pre-morbid, for most patients, you wouldn't notice much going on. Sometimes you can identify those risk factors like a stressful event, some abuse history, but again, those are kind of retrospective things you might know, because there's a lot of people that have had those same environmental exposures and haven't had schizophrenia or symptoms at all. The prodromal phase, so this is the period between first onset of symptoms to kind of frank episode of psychosis, really varies between people as well. This can be anywhere from days, weeks, months to years. During this pre-morbid prodromal phase, people can have some pseudopsychotic things, some intermittent kind of frank psychosis that in the slice of time might actually meet diagnosis for schizophrenia with resolution of that. Important to think about comorbidities. So anxiety is very, very common. If you think about that, just having people starting talking to you or starting to see people on the street that are starting to follow you, that's going to be anxiety provoking. So those are often the common things that people might experience and actually might what bring them in. And then that'll affect different things, behavior, sleep, activity level, that thing. And then we usually see decline in functioning as a result. So difficulty going to school, staying at work, that type of thing. So assessing. So we want to do a good clinical interview, obviously, psychiatric, substance use, medical histories. For these patients, getting collateral is almost essential. For people in their first episode, their experience, they're going to be naive to what psychosis is for the most part, or what schizophrenia is. So for them, that experience is real, and these are things that are truly happening to them. So you often need collateral to be able to confirm onset and impact in life and that type of thing. There are different rating scales that have been developed for assessment of psychotic symptoms, so you can track over time. The DSM-5 actually has like what they call the cross-cutting symptom measures now, which are basically tracking for symptom domains rather than specific diseases. Certainly assessing for risk is important. We'll talk about that in a minute. And then if we're doing antipsychotics, we want to make sure we do baseline aims. Okay, symptoms. This is just a busy slide with all the symptoms. So these are things we're going to look at. Patients with schizophrenia or psychosis often have disorder in the formation of their thoughts. So this is what's called a formal thought disorder. So being able to put one's thoughts together. They have a disorder in the content of their thoughts. So this is delusions that we'll see, or ideas of reference, thoughts that are inserted. Usually we talk about the delusions as having a particular theme. Hallucinations are sensory information. So this is auditory hallucinations, visual hallucinations. Auditory is much more common in schizophrenia than visual. If a patient has hallucinations in another sensory domain, start thinking maybe about something else. So epilepsy would be a common thing where patients have other hallucinatory events. Substance use or withdrawal would be another place. Illusions are the misrepresentation or misperception of true sensory data. So this is the seeing someone's shadow or seeing shadows behind them and maybe thinking someone's in the shadow type of thing. The shadow's really there, but people are misinterpreting the intent of it. As we talked before, behavior can be really significantly altered, as well as people's affect. So they can range from kind of a blunted affect, restricted affect, to really labile, variable. And then we know from neurocognitive studies that cognition, so concentration, abstraction, memory, executive control are all affected. Suicide. We need to talk about risk for patients with schizophrenia for sure. So it's the leading cause of premature death in schizophrenia, suicide. Between 25 and 50% of patients will attempt, and between 5 and 10% will succeed. So it's very high risk. It can really occur at any stage of the illness. And as a reminder, kind of the risk factors for general population, male, white, single, socially isolated, unemployed, positive family history, previous attempts, maybe some substance use, depression in there, stressors. So this is kind of that classic person who presents to the ED, newly divorced, losing their job, started using alcohol or substances again. That's kind of that classic thing that we're kind of taught, I think. When we're thinking about schizophrenia, especially first episode schizophrenia, there's some other factors that kind of pull it up out of that or make things a little different. Higher level of education, greater insight, low negative symptoms, high level of mental suffering, agitation, presence of insight. So this is, we've kind of talked about the suicide crisis syndrome, and this is kind of that overlay into schizophrenia. So this is the young patient who has enough insight to recognize, hey, I might have schizophrenia. My relation to schizophrenia is that person I see on the corner who's talking to himself. I don't want to be that person. I can't deal with this. This is really rough. So that's what makes those kind of different than kind of the general population. Things we really need to watch out for. Okay, so let's think about how this plays out. So for most patients, they're going to be what I call on like the schizophrenia pathway. So they may present originally with like brief psychotic symptoms. We have at least some months or days of syndrome or symptoms. Now they're schizophreniform. They now have this more than 6 months. Now they have schizophrenia. So a lot of people will be on that pathway. And then the other psychotic disorders include schizoaffective disorder and delusional disorder, due to medical or substances, and then the other categories. I'm not going to go through all of these. These are just here for your purview. So these are just the DSM for brief psychotic disorder. Couple highlights. Brief psychotic disorder doesn't have negative symptoms, so they don't need to have negative symptoms to get brief psychotic disorder. Schizophreniform disorder is really the same as schizophrenia, except timing. So it's 1 month to 6 months. And then schizophrenia diagnosis is 6 months or more. As with a lot of things in DSM, you can multi-code things, where they're at in their episodes and if they have catatonia or not. A couple DSM-5 highlights in schizophrenia. They removed the requirement that delusions be bizarre. Because I think just over time, or maybe just with technology, the determination of what's bizarre enough or bizarre became harder to determine, I think. 50 years ago, if someone thought, okay, I have a chip in my head that's recording everything that I see and do, 50 years ago, that would be bizarre. Today, I'm carrying a device around that's tracking my every movement. So that was one of the reasons they took that out of there, I think, because it wasn't really helpful, and didn't predict outcomes. If they had or didn't have bizarre delusions, did they do better or worse with treatment? No. Same thing with the Schneiderian first rank, like were there two or more voices commenting or not, was the content of those. And then similarly with schizophrenia subtypes. So were they paranoid, were they disorganized? Got rid of those because it didn't really impact treatment and outcomes or be predictive of outcomes. And just clinically, people could kind of go between different types. People may present with disorganized and then they come down a little bit and now they look like paranoid, and it's really hard to keep track of. Okay, little timeline. So brief psychotic disorder, remember, is just a month. Schizophreniform disorder is 6 months, and then schizophrenia is at least 6 months. And this includes prodrome, active, and residual. So if people are in treatment, but they have some residual symptoms, you got to include that in your timing. Schizoaffective disorder, it's highly overdiagnosed, I think, but it's hard to diagnose, I'll say it. So you have to have a mood disorder. So you have to have either depression or bipolar, like mania and depression. And then separately, you also have to have a psychotic disorder. So the differentiation between like a mood disorder with psychotic features is that you have to have at least 2 weeks of psychotic symptoms in the absence of mood symptoms, which is kind of hard to determine if someone presents to the emergency room or the inpatient unit and they're highly depressed but highly psychotic, or manic and psychotic. You know, it's hard to pick out. You really have to follow them longitudinally to say, okay, their depression is better, their mania is better, but they're still psychotic. So this little graph kind of just outlines some of that stuff. So to be schizoaffective disorder, you really have to have that pink hump in the beginning where they've had frank psychotic episode without any mood symptoms in order to get there. Catatonia. Catatonia is probably under-recognized, I think, a lot of times. Catatonia is a psychomotor dysregulation syndrome, and it has lots of causes. So it can be caused by a primary psychiatric disorder. It can be caused by medical disorder like metabolic disorders, sepsis, that type of thing. End result is people are really sick, and they really need a high level of care usually. So in DSM, we can categorize it connected to those things. So is this part of a mental condition? Is it part of a medical condition? Or we don't know, really. I'll put a shout out to the University of Rochester. If you're interested in catatonia and you work with patients that might have catatonia, go look at that University of Rochester Department of Psychiatry catatonia website. They have videos on how to actually do the Bush-Francis scale. They have demonstration patients where they're doing the exam on and then talking through the exam and kind of why they rated something this way or that way. It's a really good informational site for catatonia. Catatonia has these motor symptoms. I'm not going to go through this because I'm going to run out of time here. Substance or medication-induced psychosis. So this is where we have direct evidence that the psychotic symptoms are due to either the medication or the substance, and there is a physiologic connection between either the substance and the medication to cause these things, either in intoxication with the medication or withdrawal from the medication. Medical causes of psychosis. Well, back. Delirium until proven otherwise is my kind of rule of thumb. So delirium is probably the most common reason while patients are in the hospital or they might be experiencing psychotic symptoms, like hearing things that aren't really there, or seeing things that aren't really there, maybe being a little paranoid that something's going on. And delirium is really a medical illness. So there's some medical condition that's causing brain dysfunction that's resulting in psychotic symptoms. But there are other medical conditions, neurologic conditions that can contribute to psychosis as well. Lots of different substances. So here's the list. I'm not going to go through those. Okay, let's talk a little bit about treatment here. So our treatment plan. Given our etiology, we have to provide treatment that's kind of going to be matching these different risk factors and arms of what we know about what's going on. So we really need to make sure we've got the accurate diagnosis first. What's going on? Is there something treatable? Is this a medical thing? Is this a substance we can get rid of? Put a treatment plan together, working on a therapeutic alliance with both the patient, the family, educate them. When I did my first episode work at UIC, this was probably our primary goal, was educating patients and families on what is psychosis, what is schizophrenia, how do you manage when your son or daughter is starting to have more symptoms. Just giving people that information and have them be active managers in their illness can go a tremendously long way to preventing downstream effects, I think. So the more we can educate and do that upfront, the better outcomes we can. Obviously, treating comorbid conditions, attending to social functioning is really important as well. So getting people back to school, work, whatever their goals are. And then like that cross-continuum handoff documentation. So almost all these patients are going from inpatient to partial to outpatient to inpatient to partial, back and forth, and having some continuity across that system and those service lines is really important. Okay, let's talk about meds. Meds are our primary treatment to decrease the symptomatology that people are having. We've had meds since the 50s. Thorazine was our first marketed medication. All the medications that we have, except for a couple now on the market, new medications on the market, all work by regulating dopamine in some way. We have the two medications now, that Nuplazid and the xanomeline, work by a different mechanism. One just on serotonin, and the other is a kind of a new mechanism action looking at muscarinic cholinergic receptors. Our medications have tended to be divided into two categories. So the first generation antipsychotics, they used to be called the typical antipsychotics, much more directly active on dopamine. And then the second generation medications are more broad spectrum, I guess. So they work more on serotonin or some other combination of medications. I'm a fan of old advertisements. So these are some of the marketing for Thorazine, the one that came out. The one on the left, when the patient lashes out against, quote, them, Thorazine quickly puts an end to his violent outburst. So a little Twilight Zone action there. For prompt control of senile agitation, use Thorazine. Thorazine can control the agitated, belligerent, senile, and help patients have a composed and useful life. What's a little judgy there? And then there's one for prompt and sustained relief from severe mental and emotional stress. So, housewife upset about something. Hopefully you've come away from that. So how do we choose medications? We've kind of moved away from strict medication algorithms. So if you remember years ago, like I grew up in TMAP, which was the Texas Medication Algorithm Project, which was this very algorithmic decision tree about use this, then this. If that doesn't work, use that, then that. It provides general good guidance, probably. The theming is okay, but because we have more medications now, we kind of know more about how medications work and they don't work. Having those strict algorithms in today's age really doesn't make as much sense and may not be as clinically useful. We know now that with our medications, there's a lot of heterogeneity between how they work, and we don't have a lot of evidence on efficacy. Like one is, aside from clozapine, a medication that's going to be much more efficacious than another medication. So the actual choice of it depends on a lot more factors. Again, with the side effects, we don't have a great way of predicting which patient is going to have more side effects or less side effects, with the caveat now that we've got some of that pharmacogenomic metabolic metabolism data to kind of guide us in that. Okay, so how do we do it? We have to take all of this stuff into account. So we have to look at the efficacy and the side effects and what the patient's preferences are, what's important to them as far as a side effect or a side effect. Do they need something for sleep? Do they want to avoid something that's sedation? What type of formulation do we need? Is this a patient with difficulty with adherence, so we need a long-acting versus not? Are they taking any other medications, so we need to worry about drug-drug interactions? If we're doing multiple medications, are we looking at the receptor profile to make sure we're not duplicating a mechanism of action that we've already got on board? And then those pharmacokinetic and pharmacogenomic considerations as well. So this would be like the rough outline here. So choose a medication based on those factors. First generation, second generation, clozapine or long-acting, depending on the patient population and where you're at. If they have a good response, yeah, keep going, they're good to go. If it's a side effect issue, probably go back and try another medication in those first generation, second generation one, because we're just trying to look at, it's not an efficacy issue, it's a tolerability issue. So we can probably choose a lot of different medications. If it's a efficacy issue, most treatment algorithms will start saying, well, consider using clozapine early. If you have a good response, move them down into maintenance. Now, if they failed a couple of medications, if it's tolerability again, pick another medication because it's not an efficacy thing. If it's now efficacy and they failed two medications, really start thinking about clozapine. There's good evidence to say that if people have failed at least 2 antipsychotics, and they're good trials, good doses, good timing, you can ensure the adherence, they're not missing doses. If they fail those 2, there's good evidence they will continue to fail. So we got to do something different at that point. So just trying another single agent probably is not good. So think about clozapine, think about maybe doing some combination at that point. And then if that's not working, ECT. So ECT has good evidence in acute treatment for schizophrenia, not good maintenance data. So you have to use antipsychotics along with it. You can't just use ECT. But in the acute course, if someone has failed clozapine, ECT would be the choice. And before we had medications, that was the treatment of choice for schizophrenia, was ECT. Bringing back the neurotransmitters. So this is a diagram of the neuron and then where our different medications are acting. So we've got the dopamine here at the receptor. So we've got too much dopamine going on. Dopamine antagonism is blocking these receptors and having its effect here. Serotonergic medications are working higher up. So they're working at the regulatory glutamatergic neurons and controlling those. Muscarinic activity is up here. So we have different kind of methods of action now. And if we're thinking about combining medications, that's what we should be doing. So if we have a medication on board that's highly dopaminergic already, let's look at something that's actually maybe working through serotonin if we're going to combine things together. Okay, very busy slide, but efficacy data. So we have very good what they call network analysis of medications. So they take thousands of drug studies with thousands of patients and do a network analysis to look at comparing different components of the medications or like efficacy and then side effects. So on the far left is overall change in symptoms with the different medications. So it's probably too small for anybody to read. Clozapine is up at the top, and it's up at the top by a fairly significant margin to the left. This is both American and European medications, so some of these medications we don't have. But if you look at them, you can probably draw a line. Like the bars are the 95% confidence interval, so we're 95% sure that the true value for that medication is in that bar someplace. We can probably draw a line that goes through all of these, like from top to bottom, almost all of them with a single line, meaning that there's not going to be much efficacy difference between them. And then it's broken down by positive and negative symptoms too. So this middle column is positive symptoms, right-hand column is negative symptoms. Again, clozapine is at the top for the charts for both of them. Other things at the top that we have here: olanzapine, risperidone, thorazine, haloperidone. So one way to think about medications, if you're just kind of saying, okay, I want to go for most efficacious, okay, let's look at this. We can at least go down the list that way. The other way of looking at it is side effects. So if we're looking at side effects we want to either use to our advantage or avoid, we can look at these medications from that point of view. So on the far left is weight gain, kind of in the reverse. So the things at the bottom are the medications that cause the most weight gain or favor placebo, and the things at the top of the chart are the ones that are the most weight neutral. So ziprasidone, people lost weight compared to the placebo in that case. Down at the bottom, olanzapine, clozapine, quetiapine, the ones we think about are down there. And then also QT prolongation and sedation are the other two charts. So this can kind of guide us in making a selection or thinking about our next step. Shout out to clozapine. It's our most effective antipsychotic. I'm a fan of clozapine. We underutilize it because we think it's more complicated than it really is. It's definitely has high efficacy and does incur some more risk. So we have to think about that and manage that. But great data to show people will respond. So in patients who have failed 2 or more trials, the response rate is roughly 2/3. So 2/3 of people, or 1/3 of people will have a dramatic or substantial improvement, A third will have a modest improvement, and about a third will have a mild or no improvement. So in a person who's failed multiple antipsychotics, if we can get 2/3 of them to have at least a mild or moderate improvement, that's a win. It's also shown to dramatically decrease suicidal ideation in patients with schizophrenia and schizoaffective disorder. So if that's a component of someone's illness, clozapine is a good option for that as well. If we think about just kind of a very simple risk-benefit ratio, the risk of death from clozapine is about 2 per every 10,000 patients. If we compare just that compared to like the rate of suicide, and we kind of put it on the same numbers, it's like 900 to 1,300 per 10,000. So if we can make a decrease in that risk, that's a good use of clozapine. Medically, the biggest risks are agranulocytosis, so decrease in neutrophils, myocarditis, cardiomyopathy, and pulmonary embolism or DVT. Those are the acute medical risks that we're most concerned about. Most of these happen within the first 6 months of treatment. Most of them are the myocarditis, cardiac, and the pulmonary embolism are people are really sick. The ANC is not something that you would notice until people are pretty affected. So when clozapine came to market, there was a requirement that we monitor the ANC. Well, not acutely. After market, when it came out, we noticed this was a problem, started the REMS study. So the requirement was that we'd had to monitor absolute neutrophil count weekly for the first 6 months, every 2 weeks for the next 6 months, and then every 4 weeks or monthly after that first year. In February of 2025, they just changed the REMS requirement so that we have to continue to do the blood monitoring on the same frequency and assessing that, but we don't need to send it into the central REMS program in order for it to be dispensed anymore. So a little documentation burden relief there. Another thing we need to keep track of is metabolic syndrome. So this is common with second-generation antipsychotics, problems with increased weight, triglycerides, blood pressure, increased glucose. Again, we have data on medications that are more at risk or less at risk. So if we're thinking through these things and we know that someone's at risk, we should maybe pick a medication that's a little more neutral. Some acute side effects that we pay attention to are related to dopamine. So the first 3 columns, akathisia, dystonia, and Parkinsonism, are the result of excessive dopamine blockade at the synapse level. Different treatments for those, mildly, moderately effective maybe. Usually if someone has one of those side effects, we'll try and switch medications. Tardive dyskinesia is one of the chronic symptoms of excessive dopamine blockade. Has different risk factors associated with it. We have a couple new medications that valbenazine and dutratebetazine that we can use now. Put this as a slide in there just for more information about tardive dyskinesia and some of its assessments there. One of the questions is, what risk is there for tardive dyskinesia compared to medications? Not a lot of great comparative data. So even looking at this table, this isn't really a comparative risk table. This is a risk of TD in the studies for these different medications. So it depended on the population and the patients studied, but it gives you at least some idea of kind of the risk, with the second generations having much lower risk than the first generations in general. So a big thing, we have to screen for it and monitor for it over time. As I said, we have a few treatment options now. Okay, lastly, I wanted to give some information on some psychosocial interventions that have some good evidence or great evidence for helping patients with schizophrenia. This summary slide lists the ones that have at least decent level of evidence and how they've been helpful or how they've been studied. The challenge we have is how we should best combine them. So this type of person with this type of needs should get this type of intervention. So that's kind of yet to be determined and really up to clinical things. One area that's shown really good evidence is the coordinated specialty care programs. So this is like a first episode psychosis program where you have intensive, kind of like a model on the ACT team or something that's really dedicated towards first episode psychosis. So this was a 2-year first episode psychosis program. The panel on the left is looking at readmission rates. So the readmission rates, the green line is the program participants and the orange line is the non-participants. So the risk of readmission is less over time. And then the right panel is all-cause mortality in users. So really showed a dramatic stabilization of a patient's health and mortality over time in those 2 years. I talked a little bit about assertive community treatment. So this is an intensive outreach, community-based model. Patients need to be screened for this. So the patients that do well in this program are high utilizers, so lots of admissions, chronic illness. It involves intensive case management, helping patients stay in the community. And it has that good effect on housing, employment, and core illness. And then also CBT. This is kind of a niche area of CBT, so CBTP or CBT for psychosis. It's a modification of kind of the standard model of CBT. Looks at modifying the delusional hierarchy. So a delusion is a fixed false belief, which is very similar to a phobia. If I have a phobia of elevators being dangerous because of my past experience, I can use CBT to challenge that. So if someone has a fixed false belief that white vans are following them, and they're not actively psychotic, you can use CBT kind of challenge that and help patients kind of conceptualize that was part of their illness, and that isn't really a true thought. That's an irrational thought now based on their illness. Great data for this to show effect over time. So if you do an intervention with someone, they have like 5 and 10 year studies to show that this is the lasting effect for patients. They can learn to manage their symptoms and learn about their symptoms better. Okay, so we looked at nature, where things come from, risk factors for nurture, environmental exposures will lead, contributing to this brain dysfunction, symptom production, and resulting in our diagnosis of schizophrenia. We have good evidence now on where this is coming from and really informing our treatment models now. I didn't have a chance to add this, but we've got some new targets for medications and kind of some emerging therapies like TMS, looking at very specific regions of the brain. I just want to thank everybody and thank all the patients I've worked with, colleagues I've worked with. Thanks.
Rob, why don't you stay up here? We'll give an opportunity in case there's 1 or 2 questions before we break. John.
I'm just curious about the new change in lens, getting rid of that philosophy and how you see that clinically, changing your clinical practice when it comes to surveillance labs, et cetera.
Shouldn't change anything clinically because the prescribing instructions are the same. So we have to monitor everybody at the same frequency and keep track of that. We just don't have to report it to REMS anymore.
I guess my other question is Europeans kind of monitor it differently. So I'm curious if you have thoughts on that philosophically.
No. A different way of doing things, I think, yeah.
It's a little looser, less frequent, and
Yeah.
I'm curious when the risk, that surveillance itself sometimes keeps people from prescribing it in the first place.
For sure, and I think that's part of the reason they made the change was to improve access, I think. It's probably, it will evolve over time, I hope, because at each one of the committee meetings where they've gone through this, those things have been raised, and so this is probably step 1 of a multi-step transition, I would say.
So I'll ask a quick question. You didn't talk about long-acting injectables too much, so if you could comment on LAIs.
Yeah, sure. Also a big fan of LAIs. So long-acting injectable medications are a formulation of one of our regular medications that have a long half-life, and they've got a lot of technology in them, these little microspheres and the ways of kind of slowly releasing them so that patients will get an intramuscular injection either in the shoulder or maybe the hip, and lasting from anywhere from 2 weeks to 6 months now. We have one. There's also some new sub-Q injections. Rosetti is a sub-Q one. They are quite helpful for patients if they've had non-adherence. So I guess my rule of thumb, I have a very low threshold. So if someone comes back from a hospital discharge and they've had got any difficulty in maintaining adherence, they should be asked about, do you want to just take an injection so that can help you just keep up with your medications? Great evidence to show that keeping on a long-acting injection allows people to get into the recovery pathway. So we need them to have their symptoms under control so that they can get back to doing what they were doing before they became sick. So that is really our goal with that. So get them adherent or get them on something that maintains that medication.
Super. All right. Thank you, everyone. Very much enjoyed that presentation, Rob. Thanks. So we're running a smidge behind schedule. So we'll take a 15-minute break. So I've got 10:08, so we'll plan on being back here at 10:23, please. For those of you online, plan to be back online about 10:23. Okay, thanks, everyone.